This is Emily Horvath. Welcome back to the Expand podcast created by Respiplus. This content will bring you close to experts in the respiratory field who will be discussing the best practices with a focus on improving the lives of people living with chronic lung conditions. This podcast is part of a series that explores the journey of people suffering with chronic cough and their healthcare team. Today, I'm here with Maria Sedeno, the Executive Director of Respiplus and leading author of the Living Well Self-Management Education Series for Chronic Lung Diseases. I'm also here with Dr. Louis-Philippe Boulet, respirologist from the Quebec Heart and Lung Institute. Dr. Boulet is currently a professor of medicine and holds a chair in knowledge translation, education, and prevention in respiratory and cardiorespiratory health at Laval University. He is also chair of the board of directors of GINA and a member of many Canadian and international medical societies and guidelines committees. Dr. Boulet is here with us today to discuss the relationship between chronic cough and other respiratory conditions, such as upper and lower airways diseases. He will explore some of these relationships and the various presentations you might see, as well as their mechanisms.
Hello, Dr. Louis-Philippe Boulet. Thank you for joining us.
Pleasure.
Thank you for working with us in this series of podcasts with respect to the chronic cough. Mm-hmm. So today, I really want to talk about the topics of the relationship of chronic cough with other chronic lung diseases or other respiratory problems in general. So maybe I don't know what's your vision around that and how we should go about that.
Of course, in regard to chronic cough, many causes or many etiologies of chronic cough originate, in fact, of the upper airways or sometimes of the lower airways. So, of course, these are among the most frequent causes of chronic cough. So they are very important to consider.
That's a good structure if we start to talk like that. So then let's focus then first on the upper airways, and then at this point, how would you see the relationship with chronic cough, and what is the typical presentation of someone with chronic cough?
Yeah, well, I think in English we call that the upper airway cough syndrome, UACS, that has been defined by the American College of Physicians. It is in fact the most common cause of chronic cough. I think it's almost 3/4 or 70% at least of the chronic coughs. So there are many conditions that can induce a cough that is persistent in regard to the upper airways. All the type of inflammatory problems such as rhinitis, laryngitis, chronic sinusitis, and they can cause a cough that is persistent. Mm-hmm. There are some other problems that are a little bit more what we call functional, which is, for example, the glottic dysfunction or dysfunctional breathing, where somebody can have a closure of the vocal cords, sometimes following some external stimulation, such as exercise. But in fact, upper airways causes of chronic cough are extremely frequent.
That's very good to know, because that would be one of the most common presentations then. In this case, how would you say what are the most common mechanisms that are implicated involving this type of etiology with the relationship of upper airways?
Yes, well, most of the time I think it's the inflammatory response of the upper airways, either following, for example, allergen inhalation, if somebody is allergic to something in the environment, or sometimes there is no obvious cause of this inflammation, but the process can induce a cough that is persistent. Of course, if you think about rhinitis or sinusitis, there may be the production of secretions that are dropping into the upper airways in the pharynx, so that can be a mechanism to induce a cough. And there are some neurogenic reflexes that can be responsible for the cough. There are many cough receptors in the upper airways, and they may be stimulated either by this inflammatory process or by different environmental factor, dry air, all sorts of stimuli. Of course, in some people, there is already a tendency to cough, what we call a cough hypersensitivity. in fact, they react more to the triggers or the inflammatory problems than others. So if in some patients, in fact, this type of inflammation or external stimulation from the environment doesn't cause a cough, in some individuals, it's inducing really a cough because of this hypersensitivity. So we have to look at that. And we have to look at the symptoms also that can guide us on a possible mechanism. But it depends on the individual, although inflammation is the most common, of course.
So in this clientele with chronic cough linked to upper respiratory airways syndromes, how do you go about the evaluation and treatment of the chronic cough?
Well, I think the first step, of course, is to record the symptoms exactly, because cough can be associated with postnasal discharge, sneezing, nasal congestion. So very often it suggests, in fact, the presence of a rhinitis and upper airway inflammation. That can be associated sometimes with what we call polyps, nasal polyps into the upper airways, but just a rhinitis, either allergic or non-allergic, can be quite evident from the symptoms. Sometimes, of course, it would be interesting to have a look into the nose to see if there is any sign of rhinitis or inflammatory process, or if there is nothing else like polyps. And of course, for the glottic dysfunction or dysfunctional breathing, sometimes the ENT surgeon can do a laryngoscopy to see if there is an abnormal adduction of the vocal cord, the closure of the vocal cord, for example, during stimuli or during exercise, something like that. It's usually symptoms that guide us for the upper airways, but of course, some endoscopy or to have a look at the nose can be very instructive indeed. I should not forget that for the upper airways, sinus X-ray can be interesting to have a look if there is, for example, a chronic sinusitis. So it can be part of the investigation.
Let's now talk about the clientele whose presentation of chronic cough is linked to lower airways. And I'm really thinking about asthma, I'm thinking about COPD. And is this frequent? Is this another type of clientele?
Yes, absolutely. In fact, lower airways problem are probably the second most frequent cause. Another one could be gastroesophageal reflux, but they are extremely common. Of course, if you look, for example, at asthma that can induce a cough, or COPD, chronic obstructive pulmonary disease, that can also be manifest as a chronic cough. They are frequent in the population. In fact, asthma touches about 10% of our population. So lower airways can be very frequently involved in the diagnosis of chronic cough. So the way we try to look at these different diseases is first, once again, in regard to the symptoms. Well, asthma can present with only a cough, but usually there can be some wheezing. Symptoms are variable. Sometimes they can be induced by exercise or different triggers of the environment. If it's in COPD, usually the symptoms are a bit more fixed. They are less variable, but very often we have a long-term smoker. There is what we call a smoker cough, sometimes that can be present. And so we have to look at the clinical presentation, the health habits such as smoking, and also is it an atopic, an allergic patient, or there are some environmental factors, any animal at home they are allergic to, and so on. So that's very important. But of course, we have to do additional tests to prove the diagnosis. Otherwise, we can be in trouble. There is a lot of over and under diagnosis of these problems. We showed that in many studies, including recently. Yeah. So we have to perform some pulmonary function tests. The most simple test is really spirometry, pre and post bronchodilator spirometry, where we can objectivate, in fact, to demonstrate if there is any airway obstruction evident. And is it reversible or partially reversible by administration of a bronchodilator? So if there is a quite significant bronchodilator response, that may suggest asthma if it's in a non-smoker. Sometimes if it's a long-term smoker, it can be also present in COPD, although less frequently than in asthma. But once again, it's the overall clinical picture that's important. For asthma, if spirometry is normal and we suspect that there is underlying airway responsiveness, what is the main stigma of asthma, then we can do a bronchoprovocation test with methacholine usually. We can do other tests like with exercise or dry air, but most of the time these days we do a methacholine test to see if there is any airway hyperresponsiveness that suggests really the diagnosis of asthma. So there may be some other tests, such as non-invasive inflammatory measures in the induced sputum, or a test called FeNO, the forced exhale nitric oxide measurement, which is simply looking at the exhaled breath if this marker, this biomarker is higher. So, but the basic diagnosis is really done on the pattern of symptoms, characteristics of the patient, and really good lung function tests or airway tests to confirm the diagnosis. If there is a suspicion of another entity called bronchiectasis, which is a dilatation of the airways that is following infections, long-term infections, then we can use tomodensitometry to prove this diagnosis. But in the other lower airways problem, a simple chest X-ray can be helpful, not for the diagnosis of this condition, but mostly to exclude, in fact, some other conditions such as lung cancer, a tumor, or any other abnormalities of the airways.
Definitely, definitely. And so, how would you go in this case and in this clientele? How do you go about the further evaluation and treatment?
Yes. Well, I probably should start with asthma, as it's the most common. I think that there are many very good guidelines, such as the GINA guideline or Canadian guidelines that have been produced to suggest a way, in fact, to treat these patients. For asthma, the basic treatment, including for cough, it's not just for cough, but all the other symptoms. The basic treatment is inhaled corticosteroid given by mouth, of course, with an inhaler. And this is a good anti-inflammatory agent. Asthma is an inflammatory disease, so it's usually very helpful to treat. Nowadays, I think for mild to very mild asthma, it's suggested to give in many patients an inhaled corticosteroid associated with formoterol, which is a fast-acting and long-acting bronchodilator on demand, in fact, for this medication, because if they have to take this inhaler, it will include not only fast bronchodilator, a fast relief bronchodilator, but there will be also a small dose of inhaled corticosteroid that will take care of the inflammatory problem that causes usually the symptom. But if asthma is more severe, or there may be also simply giving an ICS, an inhaled corticosteroid daily, if the patient is very adherent with a short-acting bronchodilator as a reliever. But if asthma is more severe, then we can increase the dose of inhaled corticosteroid, ensure that they are taking regularly this medication associated with a long-acting bronchodilator, or in some more severe cases, give also an anticholinergic agent. And for the very more severe, the most severe types of asthma, we now have some biologics that can be useful. They are expensive, but they can help to control asthma if the basic treatment has not been sufficient. There are some other therapies or treatment that can be used, but this is really a case of specialized investigation in this case. So, of course, if we have COPD, it's mostly the pulmonary function test. Sometimes the radiologic test can help, but it's mostly the pulmonary function test that will help. And if we suspect bronchiectasis, as I said, we can do a tomodensitometry.
Very good. And maybe also talking about the non-pharmacological treatment, are there any other factors that need?
Oh, absolutely, absolutely. I forgot to mention that for COPD, of course, the basic treatment is bronchodilator, either beta-2 or anticholinergic. And if there is any evidence of eosinophilic airway inflammation, we can include an inhaled corticosteroid as for asthma. I think you're right. I think the non-pharmacologic measures are very important also. If somebody is allergic to something like a domestic animal, we have to be careful. We have to suggest to avoid contact with the allergen. We have to suggest, in fact, avoiding contacts with pollutants. If it's very polluted outside, it may be not a good time to have a run or to go outside to be exposed to that. Smoking, of course, is one of the most common factors involved. It's really affecting asthma very much, not only in causing symptoms, but it can change the pattern of inflammation in the airways and can make asthma more difficult to treat. And of course, if somebody is obese, I think weight loss is a very important component of the treatment, because this, even just a 15% weight loss can really help a lot to control asthma. So there are many non-pharmacological aspects of the treatment that can be very useful in addition to the pharmacotherapy.
Well, that's a very good overview of all these other conditions. Dr. Boulet, maybe just do you have? I just want to ask you if you have any final words for other colleagues and or educators in who are seeing people with chronic cough.
Yes, I think one of the key messages is that, of course, we can be guided by the symptoms of the patient. But for all these conditions, I think it's important really to confirm the diagnosis. Particularly for the lower airways problem, we absolutely have to do lung function tests. This is one of the main care gaps right now. If we suspect asthma or COPD, we should perform a spirometry, and if it's not sufficient, we have to do other tests. And if we do a therapeutic trial, if we try a treatment, the treatment doesn't give us the effect that we expected, I think it's important also to refer into specialty, because now we have new means of investigating these patients. We have new treatments, so we should really refer in these cases to be sure that the patient have the proper investigation and can be offered treatments that can really improve his quality of life in its underlying condition. So objective measure, and if needed, referrals are really key in the management of these patients.
Well, that's a very, very nice summary of all these potential conditions related to chronic cough. I strongly appreciated Dr. Boulet. It was a very nice overview. So thank you.
Thank you very much. I refer you to the guidelines. Of course, this is a very brief overview, but I think some of the key messages are there.
True. Thank you very much. And thank you everyone for listening today. Thank you.
Thank you.
That's it for today. Thank you for listening. We hope you enjoyed it and were able to get a few insights from our speakers. Make sure to subscribe to our channel so you don't miss the upcoming episodes. We'll be publishing a new podcast the first week of every month, so stay tuned. You can also follow us on various social media platforms. Just look for Expand Courses by Respiplus.